So let's break down fixation into a foolproof biological decision system that you are honestly never going to forget. Here is our roadmap for today. We'll start with the core fixation decision, then compare absolute versus relative stability, match our devices to that stability, look at the biological healing response, and finally, we'll clear up some common fixation logic traps. Starting with step 1, the core fixation decision. Before a surgeon even asks for a scalpel, they absolutely have to address this ultimate biological fork in the road. And it all boils down to one simple question. Do we need movement or no movement at the fracture site? Answering this single query literally dictates the entire surgical approach, leaving us with only two possible paths to go down. Step 2, absolute versus relative stability. This is where physics meets biology. On one hand, we have absolute stability. This means zero movement at the fracture site. No micromotion, no callus formation, just direct bone-to-bone healing. It's exactly what you want for perfect rigid alignment. On the flip side, we have relative stability. Here, we actually want a little bit of small controlled movement. The body senses that micromotion, forms a callus, and heals through natural bridging. It's a much more flexible biological pathway. Step 3, matching devices to stability. Let's see how our tools manipulate these forces. First up is the intramedullary or IM pin. Think of this as a sturdy rod placed right down the hollow center of the bone. Its main job, prevent mending. But here's the catch. It only gives you internal support, not rigid fixation. It can't really control rotation, and it definitely doesn't compress bone ends together. Plus, for it to actually work, it needs to fill up most of that medullary canal, or else the whole setup just gets unstable. Now imagine a system that doesn't just hold the bone, but actively attacks the fracture gap. That is your dynamic compression plate. The way they place the screws is super clever. As they go in, they actively shift the bone fragments along the plate, aggressively squeezing the fracture line tightly together. So you end up with rigid fixation and absolutely zero movement. Next, we have the lag screw, which is fundamentally a pulling system. The engineering here is honestly great. One side of the bone grips the threads, while the screw just freely slides through the other side. Because of that sliding action, tightening the screw pulls the far piece directly into the near piece, creating massive compression. It's an absolute lifesaver for small bone fragments or delicate joint fractures. Okay, this next concept is brilliant. Tension band wiring. Normally you have these strong muscles pulling bone fragments apart, creating tension. Instead of trying to fight those massive muscle forces with giant rigid plates, this system actually converts that pulling force into a compression force. So every single time a patient bends that joint, their own muscles are actively squeezing the fracture together. Let's step completely outside the body for a moment with external skeletal fixation. We place pins into the bone that stick out through the skin and connect to a rigid frame on the outside. It's literally an external scaffold holding the bone in place. This is your go-to when a wound is open or the infection risk is sky high, because it perfectly stabilizes the bone without us having to dig around and disrupt the actual injury site. And the real beauty of the external frame is how customizable it is. Basically, more structure equals more stability. A frame on just one side is simpler to apply, but mechanically weaker. Add a frame to both sides, and it gets much stronger. But if you really need absolute lockdown, you build an angled, multi-planar frame in 3 dimensions to get the highest possible level of stability. Moving to step 4, the biological healing response. So how does the body react to all this? Well, your choice of device completely dictates the biological roadmap. If you choose a rigid plate for absolute stability, the bone heals directly. Clean union, zero visible callus. But if you go with a flexible system, the body detects that micromotion and says, hey, I need to build a bridge. It forms a protective callus and then gradually remodels it right into strong bone. Finally, step 5, common fixation logic traps. Let's dismantle some widespread misconceptions. Let's rapid fire through these. Trap 1, thinking IM pins compress? Nope, they are strictly internal support rods. Trap 2, assuming external fixation uses massive damaging rods. Not at all. They use specifically small pins to avoid wrecking the blood supply. Trap 3, thinking plates just passively hold the bone in place. As we just discussed, dynamic plates actively squeeze those fracture ends together. Trap 4, assuming a lag screw grips everything equally. It intentionally slides freely on the near cortex so it can actually pull the far cortex toward you. If it gripped both sides, you'd get absolutely zero compression. And trap 5, thinking a tension band just binds bones together like wire. It doesn't. It's a dynamic system that actively converts pulling forces into compression forces. Let's lock in this final mind map. Whenever you're looking at a fracture case, ask yourself, do I want rigid compression or flexible support? Do I need an internal rod or an external frame? Can I use the muscle's pulling force to my advantage? When you break it down like this, the right tool just naturally becomes obvious. And that brings us to the most important takeaway. Fixation is absolutely not about memorizing a bunch of devices. It's about understanding force, movement, and healing biology. Once that fundamental biology clicks for you, every surgical system out there becomes completely predictable. So instead of asking what piece of metal you should grab, the real question is, which force will you manipulate?